Hi everybody, Tom here bringing you protocol of the day. Let's talk about our protocol for pulmonary edema due to congestive heart failure, otherwise known as the CHF protocol. Talk briefly today about indications, how we treat the patients in the state of Delaware, and some important considerations during transport and with the parameters in which we administer the medications that we do in our treatment. I'm going to give a quick little brief description on pulmonary edema in general and CHF. That quick little overview is going to be important because it steers our direction in how we are actually going to be treating these patients and why the parameters of the medication administration are the way they are. So first and foremost, what is the most important aspect when approaching a patient like this? What are the indications that we're looking for in a patient that has pulmonary edema and congestive heart failure? So we're already dealing with a lung problem and a cardiac problem. So obviously we start with ABCs and we're looking, and this patient is going to present extremely short of breath, air hungry, gasping for breaths, tachypnic, tachycardic, elevated blood pressure. On assessment, they're going to have rails, they're going to show JVD, grossly diaphoretic, probably having chest pain as well. So there's a lot of different avenues and chutes in our protocols that we have to alleviate when approaching these patients. But first and foremost, airway. So even in the protocols and as you're approaching, your airway assessment and management of this patient is critical. So the first line of the protocol actually says consider capnography. We'll talk about that briefly, but most importantly, these patients are going to benefit best by CPAP. So most important, and it lists in the protocol, apply early CPAP early in the contact for the patient if they are able to maintain their airway, meaning they are able to hold their head up and they are mentating properly. Because we already know that pulmonary edema is a backup of the venous system and it's having fluid in the lungs. So they are not having any air oxygen exchange at this point. They're moving air in and out. The problem is it's that oxygen exchange down all the way down in the alveoli, because all those alveoli are filled with fluid at this point. So first and foremost, we need to apply PEEP, that positive end expiratory pressure, to open up those alveoli to start to get the oxygen change going and hopefully start having some reabsorption of the fluid into the venous system. So early contact with CPAP, super critical and important. And while someone is managing the CPAP, the rest of the assessment is going in. We obviously need the monitor applied. We need to see if they're in any type of deadly rhythm at this point. Our full ALS assessment still continues, but we don't want to withhold any airway breathing management before doing anything else. That's why it's listed like that in the protocol. And why capnography is so important with this is we can possibly hear audible rails when we approach these patients. We see the JVD, we listen, we hear all of those adventitious lung sounds, but the capnography gives us another clue to see if we are dealing with a sole or respiratory patient versus we are dealing with the CHF. And we know that our normal capnography is a steep incline, a little bit of a plateau, and a steep decline, and it continues on. When you see that obstructed waveform that you see with bronchospasm in like an asthma patient, for example, you have that slurred exhalation and then the steep inhalation because they're having trouble getting air out necessarily. In a CHF patient, when you apply capnography, you're actually just going to see a very rounded waveform going through. Obviously, it's going to be much faster because they're tachypnic, but what you're also going to see is actually the level is on the low normal because you're not getting that oxygen exchange, so you're not getting that gas exchange and that buildup of CO2. So that capnography can help distinguish between a pure respiratory versus a CHF patient, but not critical in this point because we have identified that the patient needs CPAP. We've listened to lung sounds, so we're already in that direction. So our CPAP is applied, the patient is tolerating it. Some pearls when putting on CPAP in a CHF patient is depending on your particular device. We talked about when we were saying that the one that we carry has the 3 different levels. It has the 5 of PEEP, the 7.5, and the 10. This is a type of patient where they're going to benefit from starting in the middle to see how they tolerate it. So you're putting on the CPAP at 7.5. You're seeing how they respond to it for two reasons. So A, you're putting on the CPAP, it's uncomfortable, they are already air hungry, in respiratory distress, so they don't like something sitting on their face. So you're putting it on in the middle so that if we can adjust, you can adjust downward if need be, because when the patients are starting to have relief from the CPAP, you can actually start titrating it up, because the goal in these patients is actually to get to 10 of PEEP, because we want to keep that end expiratory pressure to help that oxygenation and start moving some of that fluid if we would. So while we do that, we don't want to start them fully at 10 because A, it's uncomfortable, and we don't want that stark shift in fluid initially with the patient. So briefly, we remember that you're having some type of cardiac congestion that's going on. So you're having a backup of systemic venous that's flowing back through the heart, and you're having that fluid buildup. So you're having strain on the right side. So by putting extra pressure on that pulmonary side, you're actually straining the right side of the heart. So if this patient, which we haven't determined yet, is possibly having an MI, which is one of the other acute reasons that somebody can go into heart failure, if we are putting even extra pressure onto the right side of the heart with the CPAP, we can actually cause a decrease in blood pressure. And that is something that I have seen, and I never knew that that was actually an issue that you can have when applying CPAP, but that's something that you have to be cognizant of. And the reason that we have such a high threshold for our blood pressure parameters with our medications. So we have applied our CPAP, patient is tolerating it. We have applied our monitor. We see they're extremely tachycardic. We have been able to perform a 12-lead EKG. We found that it is not a STEMI at this point. They just have some heart strain due to the congestive heart failure and the respiratory distress. So we are moving into through the rest of our protocol. So we have established IV access. This is a critical patient. So this is obviously a double line, because let's think ahead. You have two lines. When this patient gets to the hospital, they're going to be immediately placed on BiPAP. They are most likely going to be getting IV nitroglycerin at this point, and that IV is then dedicated to that medication. So if they need to give anything else, we have another line already established for them, and it's speeding up the process to getting to definitive care. But more importantly, these are sick patients, so they can have multiple medications going on, and even though they are having pulmonary edema, so fluid in the lungs, it is not out of the realm for these patients to actually get a little bit of a fluid bolus depending on their blood pressure, because we are giving them nitroglycerin at this point, and they're going to be actually getting an infusion of nitroglycerin. So we know all the contraindications and effects of nitroglycerin, right? Decreases blood pressure. It's a mass vasodilator, decreases that preload. So that's why with these patients, having that right side deficit possibly with the heart, that's why we need that elevated blood pressure to keep that preload. Because while we're treating these patients, we're giving them CPAP, but we're also giving them nitrate. So we are knocking out that preload. So if these patients are what they call preload dependent, and that is what's used to increase that cardiac output, we have to be cognizant of that. So when we are administering nitroglycerin, we know that we are always staying above a systolic of 90, right? These patients, we are keeping the systolic of over 120. And of course, before giving nitrates to any patient, they have to have an IV established, because we know of that stark drop in blood pressure. And as we said, these patients are very delicate if they have that right-sided heart failure history. So we're administering our nitroglycerin. Our first dose is 0.4, just the way we would in ACS or STEMI. What is different about this protocol is then our repeat dose every 3 to 5 minutes is actually 0.8, so 2 tablets. If you work in a system where nitroglycerin spray is used and is carried in your bags, this is where that excels, because what's the problem now? We have CPAP on. So every time we have to give the medication, we have to break the seal that we have established with CPAP to administer the medication under the tongue. And the problem is CPAP is constant flow of air, right? So it's drying out the mucosal layer, so sometimes the nitroglycerin doesn't absorb all the way underneath the tongue. So something to be mindful of. But it's also important, if you go to administer your next dose of nitroglycerin, you see that the tablet is not completely dissolved. Do not keep piling them in there. You can hold off a little bit and you can stagger your times a little bit. So your 5 minutes, you'd be leaning more toward than your every 3 to 5. And while we are administering the sublingual, we have, of course, putting an inch of paste with tape to the chest as well. So super important wrap-up concepts. We are obviously maintaining A and B first, and by us administering our medications, we are helping C. So still keeping with our primary, and we are always circling back to seeing how well our interventions are doing with the CPAP when it comes to their actual respiratory complaint. And once lines are established, nitroglycerin is on board, and CPAP, these patients turn around fairly well for us in the field. And of course, as we're managing their airway and their breathing, we are, of course, interpreting our 12 lead and making sure there are no changes. So it's also very important, like all of our cardiac patients, that we are doing serial 12 leads to make sure that once that rate slows down, that there is not an underlying cardiac insult as well that triggered this, because we have to also start thinking as we are treating the patient, and once we initially manage them, is what triggered this. So you can have patients who have a history of CHF where they have these exacerbations. You can have a patient who has no cardiac history whatsoever, and this just suddenly happened. Very common cause for this is actually uncontrolled hypertension. Think about it. You have a tipping point. You have that high systemic vascular resistance from the high blood pressure. The left ventricle is just in overdrive at all times, and then eventually there is a tipping point, and hypertensive crisis can necessarily have what we call a flash. So they literally have a flash pulmonary edema, and it presents as congestive heart failure. And these patients will be treated as such as time goes on. So first and foremost, we are managing airway, we are maintaining their breathing, we are titrating our CPAP as needed, and we are administering nitrates. So super important. Our first dose is 0.4. Our subsequent doses are 0.8. We are making sure that they are not resting underneath the tongue, that they are dissolving as the CPAP is going on. And we are titrating our CPAP up, and we are monitoring and making sure that their blood pressure does not drop below 120. And if it does, at that point, we discontinue the nitrates, take off the paste. If need be, you can even give a little bit of a fluid bolus. We're talking like 200 mLs, something like that. We're not going to super flood the patient at this point, but you can maintain, because remember, they have the CPAP on. So we can maintain a little bit of a difference just to keep that pressure up. Hope this is helpful. Any questions, reach out. Talk to you soon.